First of all, I would like to thank Professor Sernigola and Professor Vinciquerra for inviting me to this important Congress. In the next 10 minutes, I will try to describe the pathogenesis and the clinical manifestation of GVHD. Graft versus host disease is the most important and frequent complication after an allogeneic hematopoietic stem cell transplant, and which affect the results in terms of efficacy and mortality. It's important to note that graft versus host disease can occur also in an HLA identical transplant without mismatch. In the 1966, Billingham described the three necessary conditions for developing an acute graft versus host disease. First, graft must contain immunologically competent cells. Second, recipient must express tissue antigen not present in the donor. And third, recipient must be capable to produce an efficient immunological response to reject the graft of stem cell. In the human setting, we traditionally recognize two forms of GVHD, acute and chronic. This distinction is consider the time of onset of GVHD, before and after 100 days. But this classification is now less correct because we can observe an acute graft versus host disease beyond day 100. This slide depicted in a schematic way the time of onset and the various forms of GVHD. We can observe a classic acute GVHD that occur in the first 100 days after the transplant, following by late onset acute that occur after 100 days, an overlap syndrome characterized by the expression of both acute and chronic GVHD, and finally, a chronic classic GVHD that occur within 3 years after the infusion. The pathophysiology is described as a three-step process. The phase one is characterized by a tissue damage induced by the conditioning regimen, chemotherapy or radiation therapy, following by an activation of host antigen-presenting cells. A phase two, characterized by proliferation, activation, and migration of donor T cell in the target tissue. And finally, a phase three, characterized by the production of inflammatory cytokines that is responsible of tissue necrosis. Clinical of acute GVHD is manifested by one of the following features: skin and erythematous skin reaction, a cholestatic liver disease, and a gastrointestinal dysfunction. As you can see, the symptom is variable from a mild self-limiting condition to a severe and potentially fatal disorder. In the 1974, Glucksberg proposed a classification of GVHD, a staging. In this staging, each organ was staged from 1 to 4, and the resulting stages was combined to perform an overall grading system. The major importance, since the graft versus host disease is an alloimmune disease, the most important risk factor is an HLA disparity, followed by sex mismatch, female donor to male recipient, source of stem cell, peripheral blood stem cell, conditioning regimen, particularly total body radiation, and older age. Chronic GVHD is an immunoregulatory disorder that shares features common of autoimmunity and immunodeficiency. Chronic GVHD resembles a typical autoimmune disease as Sjögren's syndrome or primary biliary cirrhosis. And its pathology is less well understood. The signs symptoms of clinical chronic GVHD can intercept many organs, but the most frequent organ involved are the skin, with a clinical manifestation ranging from erythema to lichen or sclerodermatous features. Eyes, with manifestation ranging from dry eyes to conjunctivitis, with the possibility to develop corneal erosions. And liver, with an increase of indices of cholestasis and cytonephrosis, and finally the lung with a bronchiolitis obliterans. In the past, the classification of GVHD was divided in limited and extensive. Limited characterized by a localized skin or hepatic dysfunction, extensive by generalized skin and or more than 2 organ involved. More recently, the NIH Chronic GVHD Consensus Conference proposed a new classification. In this classification, each organ is coded from 0 to 3, and scored 0, no symptoms, mild symptoms, moderate symptoms, severe impairment. And this is combined with the number of organs involved. And this produces 3 categories: mild, moderate, and severe. As you can see, the lung involvement is specific. Risk factor is the same of acute GVHD, but the most important is a prior acute GVHD, and HLA disparity, older age, splenectomy, CMV seropositive, female donor to male recipient, and peripheral blood stem cell. I finish my talk, and I would like to thank you for your attention.